Good morning, everyone. Thank you for this opportunity.
She's not able to see the slides here.
So, in the words of Albert Einstein, if you do the same thing over and over again, you cannot ever expect a different outcome. Similarly, with a trabeculectomy, if you do the same procedure, it would be unwise to expect a different outcome. So, what are the challenges of trabeculectomy revision? The first is unpredictable success. Even with needling, with MMC, fibrosis can still occur. We have seen that with any incisional surgery, fibroblasts can migrate, and scar tissue is the main barrier for success. Whenever we see such blebs, we have sleepless nights. These thin, avascular, cystic wall blebs, which have high risk of hypotony, leaks, overfiltration, and infections. And we know that there are poor outcomes in high-risk eyes like uveitic, neovascular, and post-vitrectomized eye. So why is tube surgery the better option? The first main point is it bypasses the conjunctival fibrosis. We know that a trabeculectomy needs good conjunctiva to form a good filtering bleb. But in case of a tube, you can do it in not so pristine conjunctivas too. And also, you can be flexible in location. We don't have to concentrate just on the superior quadrant. We can even do an inferior tube. So it makes it extremely adaptable to a wide range of glaucomas, including primary and secondary glaucomas. So in this video, it shows in a belt buckle. Post removing the belt, we can still do a tube. So like my dear friend Dr. Sonika said, cost. There is definitely a cheaper variant of the tubes, which is the Orolab aqueous drainage implants, which can be done for not affordable patients. And we have seen consistent long-term IOP control with fewer post-operative interventions, like no needling, lesser injections, and less frequent post-op follow-ups. So the debate of trab revision, repeat, and tube is going on for many years. So evidence has shown that in bleb needling, the success rate can be between 50 to 80%, and we've seen the blebs with late bleb needling, small centralized blebs, and high pre-needling blebs to do more poorly. When it comes to the success of retrabeculectomy, it ranges between 30 to 80%. Dr. Sonika has quoted our study, but actually that study was a very short follow-up of only 6 months, a retrospective study. But we have seen that a history of prior filtering surgery does not affect the outcome of glaucoma drainage device. So even after a decade, the trab versus tube, the TVT study is still relevant in practice. So though there's a sustained IOP reduction in both trab and tube and similar number of medications, we have seen that the number of the trabeculectomy with MMC had a higher failure rate, almost 47%, and the most common reason was inadequate control of IOP. Also, trabeculectomy with MMC had a higher rate of reoperations and more early postoperative complications. A more recent study, a more recent meta-analysis of 49 studies with 16 high-quality RCTs, which compared the implants with trabeculectomy, showed that the Ahmed glaucoma valve had comparable IOP reduction, but it had very few complications like these hypotony and bleb leaks. When we look at Bowelt with trabeculectomy, though trabs achieved slightly better IOP reduction, the qualified success was much higher in Bowelt, and the safety profile was also favorable. So in conclusion, my good friend Sonika actually missed the target a couple of times. The first being trab revision is less invasive. That's a false sense of security. Any procedure, even as simple as a bleb needling, can still have its complications. Tubes are reserved for secondary glaucomas. That could be outdated thinking because it's definitely essential in secondary glaucomas, but they have shown that primary glaucomas also do well when a trab fails. Tubes are expensive, misleading argument, there's an ADI, and tube should be the last resort, but why delay the inevitable? Why waste time on a strategy that has already proven unreliable? So in summary, the secret of change is to focus all your energy not on fighting the old, but on building the new. Thank you.